So the anesthesiologist picks his anesthesia after consulting with the client and the surgeon. And most anesthesia is metabolized by the liver and excreted by the kidneys, so impairment of these would have a potential risk of toxicity. I think that's kind of a no-brainer. Okay, you've got your 3 phases of general anesthesia. You have your induction phase. The patient receives the anesthetic agent, and it can be by IV or inhalation. And during this phase, the airway patency is achieved and maintained with either endotracheal tube or newer devices, including laryngeal mask, airway, esophageal, tracheal, combi tube. You don't need to know all those blah, blah, blah. These newer methods of airway maintenance do not require direct visualization of the vocal cords. Okay, so that would be the induction phase. The maintenance phase is during this phase, the patient is positioned, the skin is prepared, and the surgery is performed. The anesthesiologist maintains the proper depth of anesthesia while constantly monitoring physiological parameters, the vital signs and oxygen. Okay, the emergence phase would be as the anesthetic agents are withdrawn or the effects are reversed pharmacologically, the patient begins to awaken. So this is not difficult. Just need to know that there's the 3 phases. Okay, general anesthesia. Okay. General anesthesia is when you have reversible loss of consciousness. Okay, reversible loss of consciousness. With conscious sedation, they don't lose consciousness. So just kind of knowing the difference between what the patient's going to be doing and what they're going to be looking like. There's CNS depression with general anesthesia. So sometimes they'll use conscious sedation so that they don't have that CNS depression. If a person can't tolerate general anesthesia, they may have to do maybe a spinal block or something. Okay, disadvantages of using general anesthesia would be risk for complications, especially cardiovascular and respiratory because of that depression. Possible renal and liver problems could be a disadvantage if they've got problems with their function of their liver or their renal system. Okay, advantages would be it's rapidly excreted and they can promptly reverse the effects when desired. And it's got the 2 different inhalation or intravenous. Okay, nitrous oxide is the most common kind of inhalation, general anesthesia, and propofol is intravenous, very common one. Okay, in addition, they might use adjunct medications for general anesthesia, and that would be your hypnotics. Versed would be a very common one. Versed is what they use in procedures, especially with children, different situations. Versed, the person is awake and conscious, but if they add that to the general anesthesia, that wouldn't be the case. But when it's used alone in conscious sedation, Versed, it causes amnesia of the occurrence, general, most often. So Ativan can be added to general anesthesia, Valium. It sedates, it relaxes the muscles. They can use less general anesthetic then. Also opiates, morphine, Demerol, fentanyl. These all depress respirations. Breathing is monitored. Will reduce the dose in an older person. Okay, a complication of general anesthesia is malignant hyperthermia, which, if you want to look on 64. 64 has a box on it. It's a rare autosomal dominant genetic disorder. It can be triggered by inhalation anesthetic gases. The initial manifestations are an unexplained rise in end tidal carbon dioxide that does not respond to ventilation and sustained skeletal muscle contraction. Okay, so it affects the muscles. The temperature rises rapidly to as high as 43 degrees Celsius, which I think on here they have is 111.2 Fahrenheit. So it is very high. It results in sustained hypermetabolism, cardiac dysrhythmias develop, and oxygen and ATP are rapidly consumed. If unchecked, the condition will progress to hyperkalemia, myoglobinuria, disseminated intravascular coagulation, which is your DIC, congestive heart failure, bowel ischemia, and compartment syndrome in the limbs. So it is, I am on page 64 in the box. Okay, so malignant hyperthermia can develop during surgery when the patient returns to PACU. So this can even happen when they're in PACU. If the early symptoms of MH, the escalating temperature, and increased carbon dioxide production are identified, suspected triggering agents are immediately discontinued. Oxygen is immediately administered with a non-breather mask, and the patient should not be left unattended. Make sure there's good IV access. The anesthesia provider should be summoned. Dantrolene is what is administered. Without dantrolene, they will die. It's a muscle relaxant. It's administered, and measures to decrease core body temperature should be started at once, continued until core body temperature is down to 36 Celsius. Urinary catheter should be placed to monitor I&O. Blood gases should be drawn to measure pH. Sodium bicarb is given to correct the metabolic acidosis, but you will give the dantrolene first, because you gotta have that to reverse it. So, insulin may be ordered to decrease the serum potassium. You remember, what does insulin do to potassium if you have too much? Hyperkalemia.
Pulls it out of the cell so it can be excreted, doesn't it?
Pushes it into the cell.
Oh.
Potassium.
I was close.
you were
Out of the cell.
on the right level. Yes. This patient may be transferred to the ICU for continued monitoring. They'll have doses of dantrolene every 4 to 6 hours, okay? So you got a good idea about what that is? Okay, so your carbon dioxide and your temperature escalating up to high levels would indicate that that's happening. It can happen in surgery or even afterwards when they're in PACU. They'll stop the agent that's causing it, which is one of your inhalants. If it's an anesthesia, they'll give dantrolene, and then they'll have to use bicarb, and then they have to use maybe insulin. The person's very, very sick. Okay, so that's a complication. Okay, then you have regional anesthesia. It's used when general cannot be used due to medical problems. Okay, so they have nerve blocks, spinal blocks, epidural anesthesia, and you should have a good idea what these are. Spinal block, they have to lay flat for a while afterwards, so that they don't get a post-operative headache. I think that's some of the main things. Just need to mainly know it's regional. They use that when they can't use general anesthesia for some reason, or, you know, like epidural. You can't put a mom under general anesthesia and let her have a baby, right? It's probably not good for the baby. Okay, so, I mean, it just kind of makes sense. Then you have some topical anesthesia. It's applied directly to the skin, ointment or spray. Local infiltration directly into the tissue, like if you got a sulcal wound or something. Peripheral nerve function is blocked at origin. Okay, then there's conscious sedation. This type of anesthesia provides analgesia, amnesia, and moderate sedation. And they'll give this sometimes with different combinations. But Versed is one of the more common ones, but they might use Valium or morphine with it. During conscious sedation, the patient is able to independently maintain their own airway. So that's a big difference between that and general. This allows the patient to respond verbally and to physical stimulation. The physician's supervision is always required, and an RN must be prepared to initiate rescue if sedation becomes deep. Although on the pediatric unit, we were trained to do that, and we administered Versed because the kids would have to have that to go down to have an MRI or something else because they can't lay still. There's no way you're going to keep them in the tube and keep them quiet. Or for procedures that would maybe give them post-traumatic stress, you know, especially if they came in and had several procedures, they'd give them Versed. Okay, so if they end up going too deep into anesthesia, then it's got to be backed off, or you'll have to call somebody and let them know, because there's a difference between conscious sedation and anesthesia, and you have to have an anesthesiologist if you get into the anesthesia part. A consent must be signed by the patient, and an IV line must be in place. Equipment to rescue the patient should be available if sedation becomes too deep. Oxygen saturation, pulse ox, breathing and level of consciousness need to be monitored. I mean, I stayed in the room. You just document, then you redo your vital signs, you document. Somebody's got to stay with that patient all the time. You can't just leave them alone. So reversal agents are Narcan or Romazicon. Romazicon. Okay, your nursing diagnosis would be knowledge deficit, anxiety, fear, ineffective airway clearance. Sometimes when they're trying to put down an ET tube, they can get swelling in the throat or have spasms. Fluid volume deficit, if a person ends up hemorrhaging while they're intraoperative. Fluid volume excess. They give them too much IV fluids and they got congestive heart failure, for example. And risk for infection, which got I in there, but not the rest of it. Risk for infection, I'm sure. Okay, so those are your nursing diagnoses. Okay, post-op anesthesia unit, that's where they'll be for that. And you'll do a full assessment. If a client meets criteria for discharge from PACU, the anesthesia provider discharges the client to the hospital unit, and that person would call up, and the person on the floor then gets a report. And I always like to get my own report if at all possible, because I like to have the information that I want. Sometimes somebody will take a report for somebody else, but it's nice to get your own report if you're getting a patient up. You can ask, like, when did they last get medicated for pain? For some reason, they don't always say things like that, or you know, you just get a good feel for your patient if you can talk to the nurse that you're getting your patient from. One thing you'll have to have memorized is your vital signs, or 15 minutes, Q 15 minutes for 1 hour, Q 30 minutes for 2 hours, Q 1 hour for the next 4 hours, and then Q 4 hours for 24 to 48 hours, depending on their status. And they'll ask this on NCLEX. It's one of those things that's standard, very standard. So the postoperative period starts at the completion of surgery and the transfer of the patient to recovery, and the purpose of PACU is the ongoing evaluation and stabilization of the patient. So the initial assessment, Who can guess what would be the first three things you would do? Your ABCs. And those would always be the answers, your airway. What do you think could be a problem with an airway? Swelling from, possibly the ET tube.
Just being so sedated they can't maintain an open
Yes.
airway.
That can happen too. They can, yeah. And then breathing, what are some things with breathing? Depressed respirations, maybe obesity. Maybe they have flail chest. Who can remember what that is? You don't count.
Gee, fine.
No, tell us what it is.
I don't want to be.
Oh,
Multiple
no.
broken ribs.
Yes, multiple broken ribs.
And it has the paradoxical chest movements, is that
Yes.
the one? Okay.
Yes.
That's
Yeah.
where you see them, how they'll.
Yeah.
Was that like
So if they've had some
septum?
type of chest
Yeah,
surgery, that maybe it's
One
painful
section
to
there, yeah.
take respirations. Maybe they've had open heart surgery, so they're breathing shallow. And then they have anesthesia on top of it. I'm giving a hard time, Bill. Okay. Then circulation, what would be some things with circulation?
Like if their extremities still have color.
Okay, what would you be, yes, that would be good. Yes, what are some things you would assess on circulation?
Heartbeat.
Cap refill,
Cap refill,
Heartbeat.
fetal pulses,
Warmth.
okay.
Kind of.
What if you just had
Surgery
a
messes with
cardiac, a bypass surgery?
EKG.
Yeah,
There would have map you did, but you also want,
yes.
no pulse deficits from,
What about hemorrhage, washing for hemorrhage? What about overload, fluid overload? So just kind of start thinking about those things. What about dysrhythmias? They have some dysrhythmias if they're stressed and they've got heart problems. Okay, so you would do your ABCs, that's your first thing. You're gonna focus on your cardiac, lungs, and GI because those have all been depressed from the anesthesia. After you've done your ABCs, then part of the C would be checking your incision site and making sure it's okay. Now, who can tell me what's real important about a surgical dressing after it's been placed in surgery? Yes. The doctor removes it. So you can call and tell them, it looks this soaked, I've drawn a line around, timed it, whatever, but they will be the ones that will take off that first surgical dressing. You ask them, do you want it reinforced or do you want to come in and see it? So how would you document surgical site? Yes, clean, dry, and intact. What would you monitor for the surgical site? Complications on it?
Like
bleeding or
Bleeding,
infection,
infection, how would you know if there's infection?
if it's
red,
hot.
Okay, red, drainage, warm,
Pus.
pus,
Smell.
smell. Patient can also have increased heart rate if they're running a fever, or they may be running a fever. So if they have a high fever, their pulse rate can be running over 100 somewhere. So that's another way you could tell that they've got infection. Okay, so when you get done with that, then you can, you know all that's stable. You can ask about their pain or check their pain. Lots of times I'll ask the nurse on the phone what the pain level is, what I think I got going on with pain. I'll have it ready so when the person comes in, I'm assessing the patient, but I've got pain medicine where I'm already taking care of that, so I can focus on the assessment, but then, I can, when it's on the floor. Now, if you're in PACU, you should have pain control coming out of the OR, so then you're just gonna be checking on critical acute assessment just from coming from surgery. Okay, so you're gonna make sure the bed rails are up, the bed is in low position, the call light is in place. You're gonna make sure you know what the level of diet is, the medications, make sure you got an order for pain meds when you get a patient on the floor. It may take you a while to get an order, and then you gotta order it from the pharmacy. I had a couple of little girls that had scoliosis surgery, and that's very painful. Or, forget the long name of it, but it's where they have the ureter tubes change position. That's very painful too, so, okay. So they'll check maybe a hemoglobin level with labs, different things, so. Okay, so we kind of talked about this already. And then when they come to the floor, you do a whole nother assessment, get your baseline again. You always want your baseline when you got a patient. You want to make sure your patient's getting better and not worse when you have them. So you gathered your data and then you check it. It's kind of simple, but we talked about this already. Then your level of consciousness is another thing that you'll monitor, and then the emotional part will come last. So you know all of your Maslow's hierarchy of needs. Your urine retention, bladder distension, your output, urinary output. Any rapid decrease in urinary output needs to be relayed to the surgeon. That can indicate many different things. Nausea and vomiting. Turn off the NG suctioning before listening for bowel sounds. Some of this stuff you guys have already been over and you know most of this, so it's just a basic assessment. And you're gonna check your drains, your dressings. So we talked about drains the other day. Who remembers what a hemovac is? What's it used for? Knees lots of times, large volumes of blood. And it's compressed like an accordion and then it fills. Who remembers what a Jackson Pratt, how it works?
like squeeze
It works
and
with
then-
suction. You'll, with gloves, you'll take off the little cap thing and you'll just push it down, fold it in half, try to get all the air out, put the cap back on, and that suction will pull out. And then who remembers Penrose? Where does that drain to?
Just like
Okay.
out.
It goes out onto the gauze, so you wanna make sure it continues to drain just right out onto the gauze.
Mhm.
And you would know if you get a return of bleeding out of an incision after there hasn't been any and the dressings are being soaked, then something's going on. You guys know what a dehisced incision is, right?
Mhm.
Who knows what evisceration is?
And
Yes,
parts
Bill.
come out of it.
Oh, gee. Privilege.
Aren't you glad you only have a few more weeks of me?
Aren't you glad you only have a few weeks of me? Basically, your internal organs are out.
Yes, they come out, yes. And what would you do if that happened?
Cover it with sterile gauze.
Cover it
Sterile
with
wet
sterile,
dressing, sterile wet dressing.
with normal saline on it, so keep it damp.
Sterile normal.
You'll monitor your input and your output. A Jackson Pratt is a closed suction drain, yes. And then, yeah, so I think you guys are good on that. We talked about it the other day. You'll pin around the area, like if you have bloody area, you'll go around and draw and you put the date on so that you can see as it progresses. Make sure you don't pull out your drains or sutures when you're pulling off a dressing. If it's kind of dried up, you know, it could be kind of stuck. So you don't want to just pull all the sutures and the drain out at one time. You want to be able to take that off carefully. Compress the reservoirs, secure the drain to the gown. You don't want it to get yanked out. You know, you want to keep it safe. Okay, post-op complications: shock, hemorrhage, DVTs, PEs, which you guys know about that, pneumonia with atelectasis, wound incision complications, which we talked about, urinary retention, constipation due to having pain meds and anesthesia, and then pain. I don't think I'm gonna talk about this stuff very much because you guys know this. And we talked about the diet, high protein, vitamin C. And there is, your nursing diagnosis would be knowledge deficit, acute pain, ineffective breathing pattern, ineffective airway clearance, impaired skin integrity, fatigue, urinary retention, imbalanced nutrition, and risk for activity intolerance.
I'm missing it.
Are you?
Page 10.
Just page 10.
Yeah.
Page 10, okay. So what I'm gonna have you do, I'm gonna have you break up in groups and work on a case study together without answers. So, you can do it.
You might want to start recording.